Thank you for joining us today. CTSNet would like to welcome the global cardiothoracic community to this live webinar. Today's discussion is on CTSNet's current guest editor series entitled Surgical Atrial Fibrillation, What We Must Do and What We Can Do. If you have questions or comments you would like to submit to the panelists, please use the Q&A function on the Zoom window. Please note that this webinar is being recorded and that the archived version will be available on CTSNet's website and CTSNet's YouTube channel. I'll now turn it over to today's moderator, Dr. Gerdisch, who is this series' guest editor.
Good day, everyone, and thank you for joining us. The title of the series I came up with because having spent several years now working toward excellence in management of cardiac arrhythmia, I realized that there are things that we absolutely must be doing, and there are things that we can do, and we're going to cover both of those. In other words, the things that absolutely everybody should be doing and the things that maybe will be ventures for the future. That's me. Our panelists today are three of the six authors for the CTSNet edition. Marc Lemaire, University Hospital, Brussels, Belgium. Marc's especially well known for minimally invasive and thoracoscopic procedures and hybrid procedures. Dr. McCarthy, everybody knows him, Northwestern University Chief of Cardiac Surgery and Executive Director of the Blum Cardiovascular Institute, Nivad, Washington Evans Hospital, and also an adjunct professor at Maryland University. We also have Armin Kiankui, my good friend, and actually one of the best instructors in AFib surgery. And Armin was nice enough to sign on to monitor the chat and to interrupt us for the questions. So Armin's going to be staffing that with us. The agenda is kind of broad. We're going to get some historical perspective, and I cannot encourage everyone enough to watch all of these videos. And you will learn things each time you watch them. Because we have folks that have been here from the beginning, I wanted to get some historical perspective. I also think, as I mentioned earlier, we need to agree on what makes sense. If we want ubiquitous application of intervention for arrhythmia and heart surgery, we need to achieve some sense of what needs to always be done. And how do we build an arrhythmia surgeon out of either an established surgeon or a new surgeon? And then there's all the other stuff, which is how do we monitor folks? What are we supposed to be doing with the left atrial appendage, especially in light of the Laos trial 3 being published? And are there other modes of therapy that we should be considering, especially with Convergent being published? Also, what are the other consequences of atrial fibrillation? So we're going to try to cover all of that in a relatively short period of time. Perfect. So, and good day to all you gentlemen, and thank you for joining us. As I mentioned at the beginning, I wanted to get a little bit of historical perspective. One of the things that I really enjoyed about watching the videos, especially for you, Pat, was understanding a little bit about that historical perspective from a person that was standing there with Dr. Cox from the beginning. And I would you probably won't mention this, but I would mention that the words Cox Maze were put together by you at Western Surgical. So maybe you could just describe very briefly kind of what the experience was like standing there with Dr. Cox in those first cases.
Well, it was pretty amazing. I mean, you knew right away that there was something important that was going on. Atrial fib was so common. We saw it all the time, even more back then in our patients. And so for Jim to have proven this operation in the lab and then be transitioning it into the clinical arena with, you know, crowds of electrophysiologists and other visiting surgeons around him was really a fascinating time. That was in about 1990 or so when he was really just starting to create Cox Maze 2. I think that lasted about 2 months, and then he went right to Cox Maze 3.
Yeah, amazing. And in fact, I think you were the second surgeon on the planet to do a cut and sew Cox Maze. Thereafter, you ventured to add in other procedures. So what was that first experience like?
I was really fortunate to be a brand new young staff at the Cleveland Clinic, and they were very supportive of it. And so Toby Cosgrove and Fred Loop were very supportive. And so Toby had a patient that needed a mitral valve repair and also had atrial fibrillation. And so after I'd done about a half dozen, he asked me, would I help him do that? And so it became the first mitral valve repair with a Maze procedure. And then we just sort of kept going from there. We mostly we were doing it with mitral operations, or a lot of them that Toby and I would do together.
And then as you were kind of refining some of the moves for the Cox Maze, was there a point where, be honest, were you ever thinking this cut and sew operation is gonna get traction? There's gonna be a lot of this done. Or did you really think that it would be limited as it was?
So at that time, there were really kind of specific arrhythmia surgeons, like each program might have one person that did it. And we thought that would probably be what happened. I remember friends would come and visit, and about, the very beginning, they were paying close attention, and about halfway through, they'd say, "Where did you put that incision? And how did you sew that up?" And about 3/4 of the way through, they were like, "Done, I'm not doing this." So only the people that were really the most sort of focused on it stayed with it. Like Hartzell Schaff up at Mayo did a lot.
Of course. And Niv, I don't think everybody knows that you, and I do mention it actually in one of the write-ups, that you made the journey from Israel to Georgetown to join Dr. Cox to work in AFib surgery and research. And what year was that?
In 1999.
And at that time already, I think you were moving along with the concept of using cryoablation as a methodology for creating transmural lesions.
Yeah, well, this was an exciting time for, I think, that set the terms for what we are doing today, because Dr. Cox realized that one of the ways to move this procedure forward would be to enable it to be simpler and be done minimally invasively. So the entire transition from cut and sew to full cryo, and actually some other devices like the Medtronic pen and some others that we didn't use so commonly, were done at that time. We even had a special cryo device that was developed by Hartford that is no longer in use for the minimally invasive, reusable, malleable. And we took the platform of the Cooper Surgical, which is today bought by Atrial, and made the first linear maze probes that some of us are still using. I think Ralph is still using. So sure enough, quickly it was moving from a cut and sew to a full cryo procedure, even in an open case. It was quicker, and we showed some good. He showed some good results then.
And then, were there not a series of published mini thoracotomy cryomazes early on?
Yes.
When was that? Because I think people have to appreciate that operation was done then.
Well, there was a paper that was published, that was presented at plenary session at the AATS 1999. Jim Cox himself presented it, and followed by, I think, a rejection from Journal of Thoracic. So the paper eventually published, I think, in Journal of Cardiac Surgery, if I'm not mistaken. But that's the first series. There is an op technique that a single author, Jim Cox, has, I think, again, 2000 and so on and so forth. But that's how early it was. Not so many give Jim Cox credit for that, but in the mid-90s, he was doing most of his mitral valves minimally invasive using the Hartford platform. I mean, which was quite remarkable. Actually, the first mitral valve repair I've ever seen was minimally invasive by him. So people don't give him enough credit, but that's not why we're here today.
No, I agree.
Only
completely,
why we're here today.
Yeah. I think it's amazing to recognize that operation existed then, was effective, and unfortunately never really got traction. I know that a lot of us do that operation now still, but it never really got traction in the broader community. With respect to minimally invasive, turning to Marc Lemaire, who has really forged the incredible path in minimally invasive treatment of arrhythmia. I think Marc kind of, in a sense, emulates what Dr. Cox did very early with one of the first multidisciplinary teams ever, Cox, Bueno, and Schuessler, working together to create ways to treat arrhythmia. Marc, when was this first time you did anything thoracoscopically to address an arrhythmia?
Well, thank you for that question, but to address an arrhythmia, Well, let's say that I had the pleasure to work in Aalst in Belgium with the group of Van Hermen and Wellens, and which were very focused upon minimal invasive procedures. I remember the first heart procedure that Van Hermen did in 1997. So they were also very keen in getting into that field, to that expertise. And at that time they already bought a robot, and we did some resynchronization, but also some AF surgery using the robot, which was at that time rather cumbersome, I have to admit. But the problem was the referral. So it was clear that certainly in Belgium, that the EPs were not very keen for sending their arrhythmia patients to the surgeon, because first of all, they thought that we didn't really understand arrhythmia. And I was lucky that Francis Wellens, let's say for Belgium, was more or less the number one person doing a lot of arrhythmia procedures, and I was trained by him at that time. And then secondly, they thought we were too aggressive, right? Because we have this I still agree, this beautiful procedure, which is the Maze procedure, and which certainly has the highest rate of success. But they are not willing, I would say, to buy into the procedure, although the success is high because of the invasiveness. So the only way to get around it was to become minimal invasive. And since I had this platform, let's say, available in the OLV hospital, we were able to start the program.
And now you have a dedicated room that's a hybrid room.
Yeah,
and how does that hybrid room, arrhythmia room, differ from a standard EP lab? If you could just give me like a couple of points on that so we understand the difference in those rooms.
Well, the importance, I think, we have the luck that our hybrid room has been designed around hybrid procedures. So arrhythmia procedures, not around TARV and mitral clip and let's say all these procedures we would typically do with a interventional cardiologist. Our hybrid room is really designed around arrhythmia procedures, because the highest number of hybrid procedures in my hospital are arrhythmia procedures. And therefore, the hospital agreed to let's say, to have a hybrid room focused on that aspect. So I think the important difference is that every imaginable, let's say, EP mapping system, ablation system is available in this room with a control room that is big enough to handle all these screens, because if you have so many systems, you need rather a big control room. And secondly, of course, but that is more standard for a hybrid room, there is a full support for cardiac surgery. So we can always get to both fields if needed.
Anything you need to do. Yeah, that's amazing and aspirational, I'd say. So now I want to get down to some of the nitty gritty in a sense. I'm going to just veer right off into lesions, because if everybody listens to all the great presentations that were done, we're going to see a lot of different things done. And in fact, for Marc Lemaire's presentation, I did ask him to move on to another arrhythmia, and he gave us a video on treating inappropriate sinus tachycardia, which is an amazing video. But I think that kind of one of the points of confusion for folks is they still want to do less sometimes and don't know when to do less and what that consists of. So, and Niv's presentation is especially poignant with respect to the importance of the lesion set, and especially in persistent, longstanding persistent AFib. I'm going to integrate that a little bit with just a couple of point by points. Is PVI alone, with or without testing, ever okay in concomitant surgery? I'll start with you, Niv.
Well, you know, in the world of I learned a new term from Twitter, EBM, evidence-based medicine. I don't think I'm actually in a position to answer. Everything is EBM today. You know, so now we have Laos 3, so we know that the appendage is a culprit because we have a prospective randomized trial, as if common sense is not existing anymore. So the point is that I don't know the answer. I can tell you though that in my own practice, my own hands, I have 2 procedures for atrial fibrillation, either left atrial appendage or a full maze.
Okay. So
because
for you,
I was burned big time in between them.
So let me pose it one other way and give me a score 1 to 10. Patient has had 2 known episodes of atrial fibrillation. Surgeon is early in experience. Should the surgeon just close the appendage or do the veins in the appendage? 2 known episodes of AFib that self-terminated. Left atrium's 4.3 centimeters.
I would ask Marc, because I want to know what's the risk of iatrogenic left atrial flutter if you do the PVI in these cases.
Marc?
Mhm. But it's a good question. So the risk is, let's say, nearly zero if you do your PVI on the left side while including the base of the appendage. And that's how we do our PVI. So when we do our PVI, we do a very antral isolation, go medial to ligament of Marshall with the clamp, and therefore we put the clamp on the base of the appendage. We put the clip or we cut on the same line as we put our line, so the lesion set. So therefore, I think in these patients, there is no risk for a flutter. We never have seen a left atrial appendage related flutter in our procedures.
That's for standalone. But
No,
what
also
if the patient,
also concomitant.
also mitral?
Yeah,
Okay.
no, mitral. Marc was discussing about a patient. We didn't know which patient. We don't know his address score. We don't know his blood. So we have little information. But it was 2 episodes of short terminating, self-terminating AF. And therefore, you could argue, certainly for a surgeon who has less experience, I would do PVI and put my clamp on the base of the left atrial appendage and close the appendage with a clip. That's what I would do. I think that is a safe procedure where there is not too much risk, I would say, of doing the wrong thing.
So yeah, and I think that little kernel of additional information to get to the base of the appendage, nobody knows it. So now people know it, and that's the kind of thing that has to be delivered. If you're going to do this, then include that, and as you said, use a clip. Pat, what was your opinion on PVI in the kind of scenario I talked about?
Well, and also the most important thing that you do, well, what's the most dangerous thing about atrial fib? It's stroke. So the number one thing you should have in mind when you go in there is to close the appendage. And fortunately, Laos 3 published in the New England Journal of Medicine confirmed that last week. So you should really go in there and try to close the appendage. Everything beyond that is treating sort of symptoms and then, things like heart failure that develop with atrial fib. I don't really do PVI alone anymore. We used to, in particular for aortic valves and coronary bypass. And if you look at the CTSNet trial, the results aren't quite as good, but they're not bad. A lot of the atrial fib triggers are going to come from the pulmonary veins. So you could be looking at roughly 60% success depending on the patient population if you do that. So it's a reasonable thing to do.
Right. So I think we, Niv, and I'm going to call on you in a second, but I think we have to always remember that there's this spectrum of substrate disease, and there's also a spectrum of surgeon skill set, and we're just trying to get everybody to a certain place. Niv?
One comment to what Pat said. The one thing that is stunning to me in Laos 3, and I think this is for me something I didn't know. We always ask the question why patients are not having so many strokes after a Maze procedure. Is the appendage or the AFib surgery? The stroke rate is not negligible in the Laos 3, even in the appendage. It's 4%. It's much higher than any of us in our own experience in our clinic when we have appendage and a Maze. So I agree with Pat, but I think that the risk of the Laos 3 presenting to us, or the challenge is that people would say, oh, well, let's eliminate the stroke risk and deal with the rest. But I think the risk of stroke is still significant if you only do the appendage.
So I think that's a super important point. I actually wrote that down when I was reading one of Pat's early papers, and recognized that from day one, if you had a full Maze, your stroke risk almost goes to 0. And it doesn't matter how sick the patient is. So you're right, Niv, there's something different. The other thing, while we're on the subject with Laos, though, is that there are various methods of closing the appendage in that study, and we know the holes in that from the previous studies that showed those other methods don't work well.
Yeah.
So I'm going to move on. I want to move on to one other lesion set briefly, and that is just a box. A box lesion set. Again, we're talking about paroxysmal atrial fibrillation, maybe not a very heavy burden. Does the box add enough to bilateral pulmonary vein isolation? However the surgeon does it, with or without testing, confirming transmurality, Does it add enough to make it worthwhile? Marc, what do you think?
Well, from my point of view, of course it does. We know that the posterior wall of the left atrium is an important, let's say, trigger and also substrate. If you do a box, TVI, posterior line, roof line, and an appendage closure, in fact, the only thing you're missing from the left-sided maze is the mitral isthmus line. So you're coming very, very close to a left-sided maze. Knowing that in patients where you don't open the left atrium, you probably will reduce your complication rate. So we prefer in I would say non-mitral valve patients the box lesion with closure of the appendage is our #1 lesion set. That doesn't mean we do it in everybody, but that's our major lesion set.
Yeah, I think, Pat, you pointed out in your talk that the aspiration should be for all mitral surgery, right? For full maze, but that you make the realistic statement that for other disease processes, even in your center, concomitant therapy may be more limited.
Correct. And it depends on the patient, and it depends on the, paroxysmal age of the patient, comorbidities, creatinine, things like that. We do tend to just open the left atrial appendage though and do a box lesion, and we bend the cryoprobe, and so you get the mitral isthmus at the same time. And so you have the mitral isthmus and box, and if you take the line over the left atrial appendage, which has been clipped, the clip electrically isolates the left atrial appendage, so you've created almost all the Cox Maze 3 basic lesions. And then we add a brief freeze on the coronary sinus because many times it's already frozen from the endocardial side.
Yeah, no, that sounds like a pretty slick maneuver, actually. Niv, what about, now, one of the things that I think that you deliver very well in your talk with respect to persistent and longstanding persistent is the necessity of a biatrial lesion set. And you talk about mapping and showing atrial fibrillation in both atria. What about for paroxysmal or very early persistent in someone who has a normal appearing right atrium and maybe not such a big left atrium? And then is there a difference in how long they've had paroxysmal atrial fibrillation? Is there ever time to do just a left-sided lesion set for you, Niv?
So I said I used to, and we actually published a paper in the Annals, I think, looking into it and defined where it starts to fail and so on and so forth. So as you know, for the sake of discussion, we always do paroxysmal, persistent, long-term persistent. I think it's actually irrelevant, especially with the new definition of paroxysmal, that if you cardio over the patient day 3, they're still paroxysmal if they're back in sinus rhythm, but we know they may be as well persistent. We used to have a different definition, so it's very confusing. So for those who are listening, I'm looking into duration as a surrogate. So there are patients that we will, with very short duration and very, very small left atrium and not thickened, that we will do that. But my general way of dealing with it, especially with persistent, long-term persistent, we go back to the question, is biatrial lesion set. Now, with the collaboration with the University of Vienna and actually Marc Ehrlich, who is the lead on this paper, this work, we map multitude of patients and with persistent, long-term persistent coming for concomitant. With ECGI, which is the cardio insight, it's a very important point because the patients are not getting any conscious sedation or anything for that. So it's like almost like what you have when you are awake and free to go out there. And we are yet to map a single patient without biatrial mechanism for the arrhythmia. Second point, the atrial septum is extremely active. First point, this is a paper under review in Heart Rhythm Society now. When you do this, you do consecutive mapping in the same patient, and we have quite a few of them, the arrhythmia looks different. This is why the anatomical approach is so successful, because it doesn't go after the culprit, it goes after the concept. So I think those 3 points really changed the way I think about it and moved me completely away from limited lesion set.
So Marc Lemaire, recognizing that endo and epicardial activity is actually different, and that there are pathways that occupy just that circuit, and you've mapped so many hearts yourself along with your EP partners, do you feel like it has given you direction with respect to the extent of the lesions? Has something substantially changed with respect to how you decide when to make which lesions based on the mapping specifically?
No, that's a very good question. Certainly with Nived's experience now of the NSAID. We also use the NSAID, but we only use it for ventricular arrhythmias because we think that for the atrial, also Bordeaux left a little bit that pathway. It is very, it's like an MRI of the left atrium. To make a Utah score, you have 10 different people scoring them. You have 10 different, let's say, ideas about it. And the NSAID also on the atrial is a bit tricky. Doesn't mean it is not helpful, but it's not always that accurate. Why? Because we have mapped several patients where we did endocardial signals, epicardial signals, and NSAID signals. And in fact, only the endo and the epi were correlating, and the NSAID was not always correlating. So on the atrial side, and not on the ventricular side, but on the atrial side. So that is for us a little bit, let's say, too early to make any hard decisions on that level. But what we have learned from patients that we map is that typical. Of course, these are not concomitant patients. We do map concomitant patients, but not let's say in a regular way. It's always in a study. But we see that, like Nivette is saying, also what Marc is saying, is that the arrhythmia is in the patients we get is slightly more complex. You cannot just copy paste the EP literature, and because if they get away with PVI and they will do it as a first, I would say, treatment option even in persistent and long-standing persistent patients. That is not something we can do as a surgeon in our patient population. Our patient population is more difficult. The arrhythmia is much more, let's say, evolved. There's certainly much more substrate available, much more fibrosis, and that's what we see in our patients. So I have to admit, for me, the vet is talking about these lesions, but for me, the minimal lesion set would be that box lesion with closure of the appendage. I would not do anything less than that. Whether it's concomitant or standalone, and then build up the lesion set depending upon the arrhythmia outcome, because that's the nice thing if you can do it on the beating heart, because then you can measure the outcome of your lesion set and understand also the mapping where you have to head for in order to, let's say, cure or help the patient.
Right. Armin, you have a question?
We do. We have a couple questions here. So I think we just answered one of them, I think. So someone sent in a question. They said, with a concomitant CABG with chronic AF about 10 years, beating heart, not cardiac arrested, what is the best approach to treat? Exclusion of LLA for sure, but bilateral PVI for sure, but box lesion ? If Cobra 150 not available anymore.
Wow. So yeah, Cobra 150 probably shouldn't be available anymore, in my opinion. But see, that's a really interesting question to me because it drives home one of the core elements of what we're talking about, which is somebody's had AFib for 10 years, they need a full Cox maze, or you can just close their appendage. Now, just closing their appendage will decrease their stroke risk. It won't get it as low as a full Cox maze. But any of those other procedures that were listed there really aren't going to stand any reasonable chance of a durable result. Would everybody agree with that? I think I'm speaking for the team on that. AFib continuously for 10 years.
But if I can just comment on that, it would be nice if in that kind of patients, you would be able to get an EP study prior to your CABG, because you would sometimes be surprised how little fibrosis there is in patients, even with long-standing persistent AF. And that fibrosis can be very localized on the posterior wall, for example. And so it is always difficult to stray. If you as a surgeon decide you need to do off pump for other reasons, perhaps a stroke risk or pulmonary or renal insufficiency, and you want to do it off pump, then perhaps adding the full Cox maze would not be for that patient, that given patient, why you think off pump is so important, the right solution. So in that patient, perhaps you should go for, let's say, and you can make a box lesion with a clamp. You don't need, you can do a clamp lesion with Tronic or Atricure. You do half on the right, half on the left, and that means you leave your preload sufficient to keep the patient hemodynamic stable. It can be tough in an AVR, but then you're on pump, of course, that's a different story. But in a CABG, typically, you can do a box lesion with a bipolar clamp also.
So actually, that's a fabulous response, because Marc's making the point that some of these folks in AFib for a very long time may not be their substrate may not be so horribly modified that they can't respond, right, Marc? So, but you'd have to have some mapping. Were you going to say something, Nev?
Yeah, I think we have to be careful with mapping, because the biggest enemy of mapping is a sleep patient, sedated patient. It suppresses some of those arrhythmias and manipulates the fact, and it's not available everywhere. But the comment is, we are all focused on standalone and mitral and this, but most of the patients, an average cardiac surgeon is going to be with atrial fibrillation, are going to be CABG patients. The denominator is so big, and 8% of them have atrial fibrillation. So I think that question requires a little bit more of in-depth answer. And my answer to this surgeon is basically, first, let's look at the data for off versus on pump in your particular patient. What's the benefit of being off pump? Because we know how controversial this issue is. So everybody is criticizing myself and maybe others on this panel, and that, oh, for you it's only a Maze procedure. Well, I'm criticizing those guys that have a combined procedure, combined problem here, and they are only off-pump surgeons. They do their cabbages only off-pump. Well, wait a minute, maybe there are cases you need to compromise on what you do. So we have to keep open mind, and I think we have to better understand the CABG population, because this is really significant. And we need to come with much more intelligent algorithms, how to guide ourselves and others what to do.
So, and everyone should watch Niv's presentation, because he will make that whole entire message extremely clear to you with respect to what you're giving up when you don't treat someone's AFib well. I'm going to use the box lesion set as a segue into the recently cleared Convergent procedure, the Converge trial. One of my partners has been doing that operation. He closes the appendage when he does it. I haven't been very involved. I actually didn't think it was going to work out very well, but the FDA cleared this device for this specific indication, and it's persistent and long-standing persistent. And it's patients with atria up to 6 centimeters. These aren't chip shots. And it did significantly better than just catheter approach. It's basically the goal here is a box lesion. So Marc Lemaire, I'm going to start with you because this is an attempt to create an every person means of minimally invasive box lesion set, so that you don't have to be a great thoracoscopic surgeon. You don't have to, there's things you don't have to be able to do in order to do this procedure. And your thoughts?
Oh, no, you're absolutely right. I think that this will be a major player in the coming years. Certainly now that it's clear, and I think they were absolutely correct to clear it. The data is there, and the data proves it works and it's safe. What is important, I think, in the episensor, the convergence, is that it is mandatory a hybrid procedure. And I have to admit, that's what I like about it. And not because it's a hybrid procedure in say as a surgical or an EP technical act, but it's also a hybrid procedure in selecting the patient. And that's what is so important. So the reason why some centers are successful in their, whether it's concomitant AF or standalone AF, is typically because they have a good understanding with their referral cardiologist or electrophysiologist. And the best way to get let's say a good understanding is to work together. And what better is to work together on the same patient. So that is, I think, the secret of the whole success. And that is also the reason why we went into that area of expertise, because we were lucky to realize soon, and we had also the environment. I think Belgium is perhaps a good environment also for reimbursement issues, that we could collaborate together in a very, I would say, appropriate way and get the selected patient. So I believe, just like you said, the convergence opens the field for many surgeons to start a standalone program together with the AP. That's absolutely right.
Pat, do you have any thoughts on the results of that study?
Yeah, I think like Marc, I think one of the breakthroughs of Convergent is going to be that the EPs are enthused. It's I was on a panel with Hugh Calkins, who is one of the co-authors, very influential EP, and he's like, it's 20% better. Like the surgeons should be embracing this. This really is very different from the results we get with catheter ablation, and I think the published Convergent procedure was sort of the floor. I think it will get better over time. Even as you mentioned, Marc, your partners are now closing the left atrial appendage with it. That wasn't part of the trial. I think that we should be able to add between the surgeons and the EP important aspects like that, the appendage closure, that will only make it better and that shouldn't add risk. One of the concerns I've had with some of the other minimally invasive procedures is that some of them can be pretty risky, and there's only a handful of people that are able to do them. And we have Marc and Armin here, who are a couple of those people, but they're pretty challenging. Convergent should be much wider adoption and a quick patient recovery, I would expect.
Yeah, I became much more enthusiastic, and it's 20%, absolute 20%. It's not 20%
Correct.
relative. Niv, did you have any thoughts on the Convergent clearance?
I think it's a good start myself. I think when you really look into the procedure, that the way it's currently being performed, it opens actually, it's quite risky because I think that it's very easy to go south with the results rather than north. And the one point I want to convey, and this is directly from our EP that are very involved, is basically you are comparing two different types of treatments in the same study. In one, you isolated as a box. In the other, you isolated as a pulmonary vein. So many EPs would say that this is really not a good study because you don't compare the same treatment. You don't have a box with an EP and a box with a surgery. That's number one. Number two, we also have to be very, very careful the primary definition of endpoint. One of the successes that is being allowed in this trial, even though it's better than catheter ablation in this trial, is successful antiarrhythmic treatment when what was failed before. That's not an HRS definition of success. So the devil advocates here, and the only reason I'm saying it is not because I'm negative about Converge, it's a message to surgeons. The devil advocate here would say, multiple catheter ablations that are being done appropriately can achieve better results than Converge. And now I think that's the next battle.
So that's an interesting point. They do have a roof lesion, I believe, in the percutaneous arm, and the EPs are allowed to do CAFE independently if they see something. I would also comment, though, that study's already been done. I mean, the study with the box lesion percutaneously has been done, and it wasn't as good as this. Now, maybe it's not apples to apples, but it's been done.
It's a different study, and we know the problems with the CASPAF. I mean,
they had one stroke. They had one stroke. They've eliminated the disastrous complication of atrioesophageal fistula. This didn't happen anymore. So these are major moves. Like I said, I was never a fan of the procedure, but it getting past these hurdles, they slice and dice the data a lot of different ways. And I think it's actually clinically relevant to look at it at 18 months with respect to what the burden is, because that's what they're after with this. They're not trying to be a surgical maze. They're trying to show that they can take the burden down, and they do very well at 18 months. It's 90% of the folks, 90% reduction in 75% of the patients. So anyway, I think that there's more to come on that. Obviously, I'm gonna retreat back to Laos because one of the important points that you make in your talk, Niv, and also comes up in Pat's publication, is that just looking at the penetration of atrial fibrillation intervention, all types of intervention, that only about 50% of the folks that were undergoing any type of procedure had their appendage closed. So we always thought that was a fait accompli. If somebody's an AFib, they're going to get their appendage closed. So do you think that Laos will at least drive that? Niv, do you think that we're going to get more appendages closed?
I certainly hope so. As you remember in the talk, we have that pyramid, and at the base of the pyramid is not the maze procedure. Only at the top of the pyramid is the maze procedure. The base of the pyramid, the common denominators of everything should be left atrial appendage closure. Now, I hope that we can, and you are definitely, Marc, doing some work there. We have to define what constitutes an appendage closure, or what's a reliable appendage closure. You know, we have many techniques and many opinions, and so on and so forth. So I think if most surgeons are going to apply either resection or appropriate application of the clip at the base of the appendage without impinging on the coronaries, I think that this will tremendously help our patients, and that's what certainly I hope for.
Awesome. So I have two other things I want to tackle briefly, and I know we're all going to run over time. Armin, were there any other questions?
We have two questions. We have one with monitoring. So somebody's asking, you know, there isn't really some sort of guidelines for following up patients who have undergone surgical AF ablation. With your experience in this procedure, what's your advice on timing of follow-up and what it involves? And then just briefly, we have another one that just is asking, what is the panel's advice on amiodarone post-box lesions and left atrial appendage management?
So for follow-up, I'm going to ask Niv to comment on that because he wrote really a sentinel paper on the importance of doing it and how it affects outcomes. So Niv, how do you recommend folks follow?
Yeah, so thank you, Marc. I mean, you need to follow up on your patients because nobody is going to do it for you. Marc has a remarkable setup with his EPs, so I think that's one way of doing it. I kind of moved away from the spot assessment, and I'm encouraging the implantation of a link or link-like device as much as possible, and not because I believe that link is going to show me better about the success rate of atrial fibrillation per the EDGER's guidance. We know it's an ongoing challenge with the 2 minutes. It's actually what I found. It's a real facilitator of the discussion about anticoagulation, because this is really elevate the discussion about can we stop anticoagulation in patients. It makes sense. So that's one. Two, about amiodarone. We did publish our own prospective randomized trial. And we showed that if you treat patients with PO amiodarone for 3 months after surgery, you have much less events of atrial fibrillation, significant less events in the first 3 months. So that's our drug of choice, obviously within the necessity of patient safety and what's with the patient. So we're not just giving it. I'm not giving IV amiodarone immediately after surgery. I don't treat with amiodarone unless the patient is showing reasonable heart rate and so on and so forth.
So I'm gonna pass. These are gonna be rapid fire now because we're close on time. I would like to hear from each of you for your most used energy source, what you do on your first pass with it to optimize the likelihood of a transmural lesion. And let's do the left atrium and right atrium separately. So Pat, you use a lot of
cryoablation now since 2013, almost exclusively. We make small incisions, and so it's a little hard to get the clamps in there around the left side of pulmonary veins. And also we can do a mitral through a 8-10 centimeter incision, and it's awkward with clamps. Otherwise you're inside the atrium. 3-minute freezes we think is important on the left side, which we're kind of discovering as we go along. I do right atrial more selectively. I probably do more than I did a year or two ago, but I agree with Niv, the duration of atrial fib is probably important, but I see a lot of people that have had 2 months of atrial fib were referred for mitral surgery. Their right atrium is normal. They have no TR. And frankly, the mapping doesn't mean much to me because I look at our results afterwards. So we're looking at 180 left-sided only patients, and anytime that they have a failure, we do catheter ablation. Only 2 were from the right side. So if you skip it because you don't want a long pump time, which I really hate, then they can do a right-sided ablation if they need it, but it's not that common.
Right. So I think it's not a pass on the right side, but it's the point that you can make that decision based on the things that you enumerated.
Tricuspid, right atrial dilatation, long-standing persistent, that kind of thing, symptomatic patients.
Yeah, Marc Lemaire, energy and how you apply it with first pass to get the most likelihood of a transmural lesion.
Oh. So we use bipolar radiofrequency energy in all our lesion sets except for the isthmus lesion sets on the left and the right. We use cryo, just the way that Pat would use it. The way we apply is we do a minimum of 6 lesions on every clamping, and we don't change the position of our clamp. I don't like it because I think you can make micro-reentry circuits by having these little, let's say, areas which are improperly ablated. Therefore, it's important to look at the generator, both AtriCure and Medtronic. If you understand the generator, you will know when you have reached transmurality. What is important with the non-irrigated system from AtriCure, you have to look that the tissue doesn't become black because it can dry out, which is not the case with Medtronic. Because if it dries out and then you make a crossing lesion on that same area, there's a risk for perforation. That is something you should take into account. And in these patients, we would apply less than 6 clampings. The right side is just like what Pat was saying. I think as a surgeon, certainly it's very easy to decide to do the right side. You look at the free wall of the right atrium. If you see the blood streaming behind it, it's all blue, and you see the muscle fibers clearly in the front of your eyes. That's a healthy right atrium. And if you see fibrosis, fatty infiltration, you see patchy areas, then this right atrium is sick. So I think as a surgeon, it's not so difficult to decide to do the right side and not to decide.
Niv?
So for our minimally invasive maze, we use the cryo, we use the argon platform, and for the open, we use a combination or a cryo only. I want to go back to actually an important point that was how you clamp, and Marc, to me, is a real teacher. About 10 years ago, I remember sitting with him at the meetings, and he was telling me that I should never open the clamp after the first ablation and ablate the second time. You may remember that conversation. And if it's more than 5 seconds before you hear the beep, you know you're not transmural. This is how I started. And actually, I can echo him because Raf just published a paper on a double clamp. I think actually you have to look at that 5 seconds as a marker for your second, because sometimes I do a second and a third and a fourth with the same clamping before I move it. One little suggestion, that's something I do a lot. I do 3 sets of double or more on the pulmonary veins coming from above on the right. But then on the left, I'm doing in an open sternotomy something that I think not so many are doing, but maybe only us. I take the clamp beyond the IVC and bring it back under one jaw behind the pulmonary veins and one above the pulmonary veins, because I think, and Marc may remember, we had a very interesting conversation, that area below the right inferior pulmonary vein may be very, very active. And this way, I clamp it the other way, and the last set of lesions around the right pulmonary veins, I'm doing that way. And Marc, thank you for that tip 10 years ago.
Yeah, so this is the reason I asked this question is because we need to make concrete for people a methodology. And I think Niv, you mentioned Ralph's recent paper on double application of the energy with the clamp on human explanted hearts, which I felt was a seminal paper because it helped us at least identify a method for creating a transmural lesion regularly and consistently. And Pat in his talk mentions that the Maze 4 actually isn't all that fast, and he was right. So I backed off the right-sided veins once I knew I could get a transmural lesion for sure. And also at his instruction, and as Marc Lemaire just described, if they got a healthy right atrium and somebody with paroxysmal atrial fibrillation, we tend to leave it alone now. So these things are evolving. I think it's important that people get the information from people like you, so that they're just like, nah, this is the way I'm doing it. And that's the way they do it every time. The other topic, were there any more questions? Armin?
There's a good question about what do you do with the cabbage patient who does not have AF? Are we now going to clip that left atrial appendage?
All of these things vary by what hospital you walk into, right? So, we've been closing appendages for quite a while and collecting data pretty rigorously. Anybody else closing appendages on someone who does not have a history of atrial fibrillation, but has an elevated CHA2DS2-VASc score? Anybody else?
No, you have to remember you increase the risk of postoperative atrial fibrillation.
Absolutely.
Yeah,
we
wait for the data.
We need Laos 4. We need another trial.
Yeah.
It does increase postoperative atrial fibrillation, though. That's very, very clear in our data. Was there another question, Armin?
So going to that, so does Laos 3 change our behavior towards discontinuation of oral anticoagulation with left atrial appendage ligation?
Unfortunately, it doesn't. Anybody have a comment on that?
Well, that will only happen if you do your own follow-up, because the cardiologist will not stop it. So, and it's interesting also after the Maze procedure, there's plenty of data to show that you can stop anticoagulation, but if you don't check your patient yourself, they will not stop it.
Absolutely.
Yeah.
We get it off in about 3/4 of our patients, but it's because we pursue it. Anything else, Armin? Before I'm going to wrap up with a couple other questions.
Sure. The left atrial appendage seems to be a popular topic. So while doing a mitral, is closing it from the inside good enough?
We're all going to shake our heads no on this, right?
Not in my hands.
Yeah.
So I always thought it was, and then we did a little prospective randomized trial at Northwestern, and we had to stop it partway through because I was just stunned that my own double layer closure patients at 3 months on CT scan were leaking, which is what the data had shown. And so we switched to using a clip years ago, even though it's more expensive. I was amazed that it really wasn't working.
Yeah, there's still a lot of people that just won't give that up. And it doesn't matter how great a surgeon it is. It's a matter of tissue and tension. Anything else?
It always looks good at the intraoperative TE. Always look good.
That's right. So one of the things I wanted to just touch on again briefly, I mean, all of these things were kind of too brief on. We could talk about all of them for an hour each. But the development of an arrhythmia surgeon, Pat, what are you doing with your fellows? Fellows. The last time we interviewed fellows or did a survey of fellows, 77% of them said they were not comfortable with treating any arrhythmia.
Yeah, they wouldn't say that at Northwestern. So, we have our Friday morning conferences. We talk about it regularly. They see a lot of this operation. AATS has the Jim Cox Fellowship for people who are highly motivated, who want to spend a week or two at an institution to learn about it. I think because of COVID, it was on hold this year because it is like on site in the hospital, but it'll start up again, hopefully very soon. And I think sessions like this help. Industry has sessions. People have to kind of read about it and understand about it. And I think all of us on this call are approachable. Send us an email after the session and if you have questions.
Yeah, I think the Graham Cox Fellowship has been wonderful. I've had some of those fellows myself. It's been a great experience. And I'll also mention that for surgeons who really want to dedicate some portion of their career to this, this year there will be slots for fellows to apply for a fellowship that's in the name of my deceased son, Matthew Gerdisch, that will be specifically allowing folks to spend serious time in serious places with advanced arrhythmia therapies. Marc Lemaire, that would include you as a matter of fact. Marc Lemaire, what about the training that you're doing for folks doing hybrid procedures? In other words, who are they that are showing up? Do you have fellows? Are they the cardiac fellows? Are they people that are slotted for this type of intervention?
A very interesting question. So on the EP side, my center has a big number of EP fellows coming to the ERA into the program, at least 5 years, and they all mandatory go into the hybrid program. That means they do procedures. So it's not the number one EP who's doing the procedures, it's the EP fellow who is doing my hybrid procedures, of course supervised. every fellow who comes to my center from outside, also, if he's willing, now a fellow from Leuven, so if he's willing to spend 6 months, and that's once a week. So we have 2 hybrid days a week, but he's invited to come 1 hybrid day a week, and they are trained. When he leaves after 6 months, he's capable of doing, let's say, at least AF ablation and some other hybrid procedures. And I think that is mandatory. It is our task. I mean, we can show the world we can do it, but as long as we don't get the other surgeons comfortable with this procedure, it will never be successful. That is our task.
Yeah, I've met a couple of your students and they are extremely enthusiastic, if not thrilled. So congratulations on that. Niv, I think if anybody in the country's done a lot to get active surgeons to do the operation well, you're definitely in the top 3. That would include me, as a matter of fact, because right now we're doing ISAFib, your study for cryoablation. And I think one of the reasons that study is going so well is because you were very concrete about the operation, how to do it, and proctoring. Can you give me some insights in what you think for the surgeons that are out there, how they might advance their case?
Well, I think, you know, we are looking back into our professional development type of journey of others, and we realized, you know, what was done right and what was done wrong. And being dogmatic is the last thing we need now. There are quite a few truths around AFib. One of them is probably the LAAO. So I think that's the one thing. The second thing is that we need to make sure that surgeons, and especially young surgeons, but any surgeons, are comfortable in explaining why they do and what they do, and communicate well with their cardiologists on the differences between the different procedures and the expectations. But more importantly, I think, and this is where we failed as a whole, I personally admit, is that we weren't able to bring AFib into the point that people realize that when you leave patients untreated, you actually not do them well most of the time. And I think that's where we have to start, why we do it. So AFib is always, you know, I remember I went to see one guy who became my partner. I went to see him doing a cabbage as part of the survey, you know, how to, you know, whether he's a good surgeon. And he did bilateral pulmonary vein isolation, the same procedure. So he's doing the bilateral pulmonary vein isolation, put the clip, and then he says to everybody, now let's start the reed surgery. So AF is a side work. And I thought it was an interesting comment. I didn't take it personally, but I think we don't respect atrial fibrillation as surgeons. And we don't make our referring cardiologists respecting it as well. So that's the main thing.
Right. And that's very well delivered in your talk. Marc Lemire, I'm going to go back to you just for a minute because I hope everybody's going to look at your video, treatment of inappropriate sinus tachycardia, which we all know is actually a really common disorder and very vexing. One of the things from your video, when I watch it, what you do, you do it very elegantly and beautifully, but it looks simple. It looks like, you know, this is very doable. The combined work of the EP and the surgeon on this is a really ideal staging for treating this disorder. So I have a couple questions for you. One is it as straightforward as it looks? I mean, you make it very straightforward in the video. So anybody who can do thoracoscopic vein isolation can probably do this, correct?
Absolutely. Anybody who has any thoracoscopic AF ablation experience will find this, let's say, the minor procedure. The only issue, of course, is these are typically young patients. So you don't want to have complications. You don't want to have an AF, but even less in a 20-year-old lady. So that is the important. So you have to be sure that you don't take any risk doing the procedure. But the lesion set is very straightforward. It's 3 clamps, crista terminalis, superior caval vein, inferior caval vein, taking into account the sinus nodes, which has been mapped by the EP. So it's a very, in fact, it is based on a linear anatomical lesion set, like is the Maze procedure, but much more simple.
Yeah, how many of those have you done now?
We are over 300 now.
Outcomes?
Outcomes, well, So the first publication, we had, let's say, 96% success rate, which is tremendous, of course, because it's a non. I mean, if you look at the guidelines, it shouldn't be treated by an intervention. That is the guidelines. It's 3B. So you shouldn't do it. Now, of course, we have, as always, your first 50 patients are very selected, and now we tend to open a bit more to other, a bit older patients also, more obese patients, and we see that the outcome is a bit less, but still above 90, around 90 is more or less 89, I think, was the latest. But I think if you take into account, let's say the non-existent complication rate, because it's really a very simple lesion set, it is certainly worth, let's say, the try in most of these patients.
So, you know, one of the interesting things that you show, first of all, I think the rhythm changes during the video, but you make the comment that the sinus node or the primary activation site migrates inferiorly, which is Dr. Cox has described this to us for a long time. That as you ascend, the higher rates, and as you drop down, the lower rates. And is that all part of that organic aspect of the sinoatrial complex?
Absolutely. So in fact, the whole idea, it's really true, is based upon Dr. Cox's work. We just adapted it to another arrhythmia, and even I know that he already did cases, similar kind of procedures for this arrhythmia. Not the same lesion set, but the idea was similar, and we were just able, thanks to the hybrid. I think that is the real message behind this hybrid procedure. I don't think that the hybrid procedure is, in say, a better procedure than a standalone and a touch-up in a second phase, like a dual-step procedure. But the fact that you're working with the EP in one room gives you so much, I would say, mental strength towards a lesion set, towards an ablation decision. That it gives you, let's say, the strength to perform lesions that perhaps otherwise you wouldn't, let's say, be daring to do in the beginning, because you have to imagine you have a 3B indication, and suddenly you start to operate a 20-year-old lady. So you better have your EP backing you up, I can tell you.
Yeah. Any other questions, Armin, before we wrap up? I can't hear you.
Oh, I think we're all set. Everything looks good.
Awesome. Gentlemen, if you have anything you'd like to add, feel free. And otherwise,
the only thing I'd say, Marc, is that, you know, surgery has really evolved for atrial fib. You used it. I mean, look at it. We went through 1, 2, 3, 4 versions of the Maze procedure. We went through various technologies. We're talking about the lesion set, and we're not finished. But this year in particular, I think between Laos 3 and then Convergent, we're going to get a lot more interest from surgeons and EP in this because those are pretty convincing randomized trials. Let's hope so.
Never, Marc. Any final comments, never, Marc?
Hey, I just want to thank you and CTSNet for taking the time and putting this. I think it's important, another step in the right direction for all of us. And hopefully we'll have some continuation. Thank you.
Yeah, super fun.
So same for me. I think it is crucial for us to understand that AF and any cardiac arrhythmia that gives you a symptomatic patient should be treated. And that is the message. And luckily, the surgical community is giving us now more and more data, randomized controlled trials recently, that can convince us to do this procedure.
Yeah. Okay, thank you all, gentlemen. Thank you for taking your Saturday, and thank you, Armin, for helping us out with the question and answer, and all of you folks who stayed with us so long. We really appreciate it and look forward to talking to you further. Have a great day, everybody.
Thank you.
Bye-bye.
Bye.